We're going to move on to a similar topic, real-world data, this time from Poland. Rob Flisiak is going to report on the Polish real-world experience with the ABV3D regime. Robert.
Thank you very much for inviting me here to present on behalf of the study group of AMBER study, efficacy and safety data in our patients cohort. The objective was, of course, safety and efficacy data of aritaprevir, ombitasvir, and dasabuvir combination with ribavirin possible in genotype 1 infected patients. And at this moment, according to my knowledge, it's the first real-life study in this population with this regimen. Treatment was provided according to label. AMBER study is the multi-center, investigators-initiated, manufacturer-independent study, open label. Medication was provided for patients who do not have access, were expected to do not have access to interferon-free regimen in coming few years. Just to clarify, AMBER, it's a precious stone, and it doesn't necessarily mean borderline DDI only. So just keep in mind. Treatment was provided according to current label. Majority of our patients, because the study included also patients with genotype 4, but in Polish population, we have clear predominance of genotype 1. So at this moment, we included this group of patients, which is 196, and majority 186 are those who are included in these presentations just because they have genotype 1, mostly genotype 1b. As you can see, a large majority of patients were fibrosis F4, and if we look only for fibrosis advanced F3 and 4, it will be 6% of population treated. In this population of patients, predominant were non-responders and 38% were null responders. Only 21% were naive patients. As you can see in baseline characteristics, I want to focus only on the crucial markers. There were included patients with low platelets, low albumins, relatively high Child-Pugh score, and MELD score. So here are current status of response. Among 125 patients who completed therapy at this moment, only 2 patients didn't achieve target not detected at the end of treatment. One of these patients finally responded, so achieved SVR. So there was only 1 patient who didn't reach among 40 who were available in the follow-up period. So 1 patient who didn't respond. And these patients stopped medication just after 2 weeks of treatment because of suspected hepatotoxicity. If we look into adverse events which were reported up to now, because study is of course ongoing, the most frequent were fatigue, nausea, and headache, so nothing special. And it's clear that a regular adverse event and serious adverse event were seen almost exclusively in patients who received ribavirin. Among on-treatment laboratory abnormalities, it's worth to mention that hyperbilirubinemia was almost, except 1 patient, seen in ribavirin-treated patients, and anemia with hemoglobin below 10 gram per deciliter was very infrequent and also seen mostly in patients with ribavirin. And it's worth mention that ribavirin dose was reduced in 25, and discontinuation of ribavirin was in 8 subjects. I just at this moment want to comment that from the practical point of view, to treat with ribavirin or not to treat, let's start with ribavirin, and if patients do not tolerate it or doctors do not tolerate it, let's stop it. If we look to other function tests, it's obviously aminotransferases decreased significantly both in cirrhotics and non-cirrhotics. INR was during the treatment parallel in these both groups without any changes. But interestingly, platelets rate and albumin concentration tended to increase during the treatment, irrespective of cirrhosis or non-cirrhosis. So, concluding, from currently available data in AMBER study, we can take just 2 conclusions. First of all, we see rapid suppression of viral replication on aritaprevir, ombitasvir, dasabuvir treatment combined with ribavirin in part of patients. Of course, it was demonstrated to very quick decline of viral load. It was demonstrated even after 1 day by 1 to 4 logs. Undetectable HCV RNA by 30% in just after 1 week of treatment. RVR was achieved by more than 60% of patients, and undetectable HCV RNA was in 98%. Finally, at this stage of study with available data of 40 patients, we reach SVR in 98 patients, and according to my knowledge, which I get just during my trip to this meeting, probably there is not only 40, but at this moment we can say about 60 patients, and only 1 patient at this moment is non-responder. Adverse events were infrequent, mostly mild, and related to ribavirin administration. Thank you very much. And thank you for centers which participated, 15 centers which participated in this study. Thank you.
Robert, that's very impressive. It's nice to see the real-world data kicking through. Very impressive study. Time for a couple of very quick questions. Ira.
Thank you. Could you say a word about the hepatotoxicity case?
Yes.
Any worse than the one that they treated through in most of the trials?
Yes. This patient get into the grade 3 suspicion of hepatotoxicity because of hyperbilirubinemia on the level about 8 and ALT about 600. So I'm not sure if we should stop. It was not my case. It was a case in other center. I'm not sure if it happened to me. I will stop the treatment. It's difficult to judge. Maybe I will put this patient into very close monitoring in the hospital.
Final quick question from Stefan.
Robert, with respect to the use of ribavirin in the 1Bs who have cirrhotic, we have seen the data at the Berlin meeting where AbbVie has run a study in 1Bs with cirrhosis with 100% SVR rate.
Yes.
Is that influencing your trial? Are you still keeping cirrhotic 1Bs on ribavirin, or are you now enrolling and not treating with them with ribavirin? And is this data set provided and shown in Berlin? I think it was you, David, who presented these data. Is that really sufficient to to make a decision to skip ribavirin in the cirrhotics?
It was presented by Jordan Feld and Turkus 3 data, and it was really impressive because in difficult-to-treat population, 100% without ribavirin. Of course, we start medication much earlier, but our data, I mentioned that so many patients, we stop ribavirin on treatment in our study. So our data more or less support this concept that we don't need ribavirin in genotype 1b patients, even if they are cirrhotics.
Okay, thank you very much then.